Yeah. Now I told him. Unactivated, I see this on both ways. Unity without accountability.
Hey everybody, thank you for tuning in. My name is Majesty, aka Majestic. I'm here today with a very special guest, our first queen on the podcast, and I'm so excited to introduce her. This is a very special topic, sensitive topic, but this is definitely something we need to talk about in our communities. Today we have with us a doctor by the name of Dr. Dooley. Dr. Dooley, how are you today?
I'm doing pretty good. Thank you.
Good to have you. Good to see you. Good to have you here with us. So can you tell us a little bit about yourself before we get into this?
Sure. So as you stated, my name is Dr. Leigh Ann Dooley. I'm a board certified psychiatrist practicing in Georgia. And currently my practice is an outpatient practice, primarily medication management. I work in a federal hospital system, primarily caring for veterans. And originally I'm from Arkansas, so go Hogs.
Oh, yeah.
But I'm currently living in Georgia, so outside the Atlanta metro area.
Oh, nice. So I wanted to bring you on here to talk about, because on this podcast, we talk a lot about mostly the economic things that affect our communities, but we usually don't talk about things like mental health. And I feel like that's extremely important. There's a lot of discrepancies about it. There's a lot of miseducation, misunderstanding about it. So I definitely feel like this is important for us to clarify some of these things that go on in our communities and how we can deal with some of these things. So one of the things I was researching on is about how they affect mostly kids from a certain age group. And I wanted to talk to you a little bit about that. So from where I'm from, originally I was born in the Bronx. I'm from Yonkers, and those are two very tough urban areas. And there's a stigma there about you got to be a tough guy. You have to be like this guy to like, you got to wear the pants and wherever you go. So I kind of wanted to kind of get your take on that and your opinion on like that stigma and how like that culture buildup affects our mental health as people.
All right. So it's a really good question. So I guess let me tackle the stigma piece. So
okay.
In my thought process, stigma is really just the kind of shame that comes around, mental health and mental health diagnoses and treatment. And for me, what tends to drive stigma, number one is fear. And number two is misinformation, like you said. And so I think already in communities where there's, and when you say tough, I'm assuming you mean the kind of tough situations where we have socioeconomic issues. We may have high rates of violence in those kind of communities, lack of opportunities. And so when we're growing up in those situations, we have that. And especially as it relates to kids, since you described them specifically, I think the one thing we dismiss a lot is how much trauma it is for adults, but kids who grow up in a situation where they know people who have been killed, they may have witnessed that or just other violent actions. They may see drug abuse firsthand, they're witnessing that. I think a lot of times is dismissed. We just get used to it.
Yep.
And so we're just like, oh, that's, such and such, is just on substances or, they died or even just all these traumatic things. So they have a term for this called adverse childhood experiences. So even if something doesn't maybe reach the level to be that we would think is a trauma, it's an adverse childhood experience. So for me, one thing is to always take into account that, just like that baseline where a lot of people are coming from in tough places. I definitely think and again, you're a man. So I know a lot of the tough persona. I guess women can have it too, but I think it is more for men to be that way. Like we don't show emotion, nothing bothers us. And honestly, it's a really kind of dangerous situation. So you have people who have all these adverse childhood experiences, violence, substance abuse, all this, and then they are basically taught not to show their emotions or they don't know how to process things. We see what the outcome of that is. It's very predictable, and so what I try to help people understand, like in my healthcare system is, especially kids, when we see these activities and we're like, oh, they're during the election, they had that term super predator, from back in the day. They're not, they're the result of their situation and their circumstances, and so what would we expect people to turn out as with what we just described? I mean, it would take a lot to be like an upstanding citizen if you had all these adverse experiences and trauma. You don't have resources, you don't have guidance. What would we expect? So I guess that's in the clinical practice, that's what I see. And especially with Black men and brown men, to really try to, when they present, a lot of times they get pegged as being very like aggressive or violent. And people just miss sometimes that they have a mental health issue.
I actually have to say something to that. That made me feel really good that you acknowledged that, because when I go into places, I feel like I have to hyper monitor myself in certain situations, because I know that if I speak too loud, or if I do something that may offset somebody's emotions, it kind of like, it leads to this guy's really aggressive, or this guy's not really a nice guy, or, it's like so many different things that come into play with that. And you touched on a lot of good points, like where I was growing up. And yes, there's a lot of socioeconomical issues that go on where I come from. And there always was a stigma, even growing up in homes. You had to be the tough guy. You had to be, don't cry, don't show emotions. And if you do show emotions, you're showing a sign of weakness. And believe it or not, it actually has more of a negative effect on you than it actually has a positive effect. It really doesn't make you grow up to be any better. And it kind of like you kind of start to dismiss other people's feelings with that, where someone feels something, you're just like, grow up, be a man. So then, okay, that's what we're going to do. So then it turns into anger and rage, and it translates into something like crime, or it translates into something like, oh, I'm going to I got to be the head person of this block. You know what I'm saying? So when I was doing the reading and the research behind it, it made me very emotional, because of all the stuff I was seeing, and realizing, like, as you were saying, it is mostly a man thing, where we have to be like these tough guys, or we have to offset certain people from us and say, I run this. And there's actually a high suicide rate amongst our men. And we have this stigma again too, where it goes, don't see a shrink, don't see a therapist, don't see a psychiatrist. But another part where that stems from too is the distrust that we have in the medical system. So what are some things that you do to create trust within some of those people, like some of our people, when they come speak to you about these kind of situations? Because just right off the back, I already feel comfortable just talking to you, knowing that you already took that into consideration,
Yeah. And just one quick thing, like I mentioned, I work in the system with veterans. So I mainly work with men. There's more ladies, but it's primarily men in that system. And I tell you how many times I would get a patient and people would say, oh, be careful, they're aggressive and all this. And then I would see the person, and the person may have like emotion or mannerisms, but it's things that I'm used to. So I do not perceive them to be threatening. So if I see a Black man and he's, speaking a certain way or using certain mannerisms, I don't necessarily perceive that as aggression toward me that other people might, if they're not familiar with like the community and just how we express ourselves sometimes, So I think that just kind of just to piggyback on what you said there. So how do I make people comfortable? So what I do first is I acknowledge that the mistrust, that there's, a reason behind it, right? I'm Black too. So it's like, I grew up, understanding about the Tuskegee experiment, or even just seeing my friends and family. Like I said, I'm from Arkansas, I'm from a small town, and kind of seeing how they would be treated in the medical system, just my direct experience. And even as a medical student, seeing how people would be treated or dismissed. So I start by just acknowledging it when people have mistrust. And then the second thing, if people are open, I'll ask them what they're most concerned about, particularly as it relates to psychiatry and mental health. I honestly have had someone come to me to think like the brain was actually going to be shrunk, and it seems kind of funny, but if you don't know, you're seeing a shrink, people don't actually know what happens. They don't know what happens in the office. Really might think you're going to really like do something to like harm them or control their mind or make them a zombie. So I like to ask, like, what is your, biggest worry, or what do you have the most mistrust about? And then the third thing I do is I try to tell them like what the limits of privacy and confidentiality are. So one thing, and you probably have gotten this growing up, is like we have a tendency to not want to talk about our business outside the family, right? We don't want to do that. And so what I like to do is just be honest with people. I say, hey, the things that you talk to me, confidential and they're private, except in these situations. I'm a mandated reporter. So if you tell me anything about the abuse of a child, or if I suspect it from what you tell me about a child, an elderly person or disabled person, I have to report that. There's no getting around it. So I think just kind of, if you talk to me about wanting to go harm someone, and it's very specific. You have a plan, you have a weapon, and that's something that I have to report, So I think those are really the kind of times where there may be an intervention I have to do. So I lay that out at the beginning. I say, everything you tell me is private, but if you tell me these things, then I'm going to have a different kind of intervention outside of us too. So that usually, I think, laying out those ground rules and people kind of know what to expect kind of helps with some of that, the misgivings.
Right. I think that's very important to establish those grounds, because usually, even when I first kind of thought about seeing therapists, I kind of thought that if you see a therapist, you automatically get prescribed medicine.
Oh, okay.
So like, I was thinking to myself, well, no, that's a psychiatrist and they have to bring stuff to evaluate all that stuff. There's different. So, and I thought to myself, well, if I tell this person this, she's going to tell my mom, or she's going to tell this person this. And no, it's not really like that. It's a totally different experience actually when you actually sit down, speak with somebody and get the logistics of how all that stuff work. And it's so funny that you said that about the business part, because that is definitely something that is in our communities, where it's like, this is my home. You don't tell anyone anything that goes on here. So it's like, we also have that circling around our head, where it's like, they can take our information and use it against us. So they can take this and say that I said this when I never said that. And so another thing I kind of want to touch base with you on too is kind of like the stigma around how we view how we kind of degrade ourselves through, like, if someone's doing something, how that eventually affects us as an overall people. So like stuff in the home, the abuses in the home, and how we, again, goes back to that, keep it to ourselves, how that truly affects us, because that can lead to anxiety, that can lead to depression. And what tends to happen is we never get, how do I say this in a way to make it make sense? So I always tell people this, when is it okay to blame the kid? Because a lot of times we'll see an adult male act a certain way in a situation and assume he's old enough, he should know how to deal with that. But if you never dealt with those things as a child, it's going to be difficult for you to understand how to deal with these things as an adult. So a lot of times you'll end up getting into a bad relationship, trying to fix something that happened in your past with this person in front of you, or, so what, have you had situations where you had to like find ways to break through that cultural barrier? Because you are very, as you're showing, you're very culturally aware. So have you had to find ways to break through that barrier to get through to somebody, like, that's okay, like to have somebody step out of their norm?
Right. And I think particularly as it relates to like expectations about what people can, what they're capable of emotionally, to me, that's just a whole nother skill set. You can be super intelligent and have all kind of other skills, but being able to relate to people interpersonally and have good emotional functioning, picking up on people's emotional cues and reading body language, to me, that's just a whole set of skills. And some people are just more naturally prone to it. But to your other point, when I talk to people, because, we all got stuff, right? We all got issues. We all got stuff we're working through. Most of us bring something from childhood into adulthood that we're trying to process. So how I kind of try to explain it is, so the things that happened to you when you were a minor, for the most part, most of us, we didn't have really a choice, right? We're not really, it's really not our fault. If we had abuse or where we grew up, we didn't get to pick our parents, we didn't get to pick our families. We were kind of in that situation until we were old enough to do something, else, or had the resources to do something else. But what I say is, we can't change though, unless we accept responsibility. So I say all that other stuff. And even when people have traumatic experiences, again, in the work that I do, I have a lot of people who've been traumatized, from military combat or from other situations. They signed up, but they didn't want to have to go to, Afghanistan or, these other places and possibly kill people. They didn't want to do that, right? They were doing it as part of the thing that they had to do. And so what I say is, the only way we can change starting today is to accept responsibility from this point going forward. Let's say whatever has happened, the things that we didn't have control of, we can let other people be responsible for that, right? The government, our families, but we personally cannot change until we start to say, hey, I am responsible for the outcome of all of my decisions right now. For adults, kids is a little bit different, but for adults, if otherwise, I'm going to always be attributing my decisions and my emotions to other people. I say, you're in charge of your emotions. It's a choice. It's a choice if I want to feel angry. I'm in Atlanta, you're in a city, the traffic is horrible. If I wanted to let every slight when I'm driving somewhere bother me, I would be just emotionally unstable, So sometimes we have to make a choice about how I'm going to react. But that's a really high level of skill, what I'm talking about, to have that kind of understanding of your own emotions, know how to process your own emotions. It really takes work if you have never been taught how to do that. But accountability and responsibility is the key. And the people who have seen me know one of my other sayings is there's consequences to this decision. I'm not going to tell you what decision you need to make, with few exceptions. A few exceptions where I'll say this is a bad idea, like domestic violence, possibly. I may give very direct suggestions, but I say, there's a natural consequence to fill in the blank. Staying in this marriage, whatever the consequences are, So I think we have to learn how to be accountable and responsible, and just accept even good decisions have natural consequences, and we cannot always predict what those are.
That's a very good quote. I heard one time in church, they said to me that expectation is premeditated disappointment. And it kind of ties well with that, where if you have this expectation of like where you think everything's going to be as it was when you were a kid, and you're trying to fix everything from your past rather than just actually go to somebody or find something that can help you fix that out, you're going to constantly deal with these things, and that in turns into be your responsibility. One other thing, now that we're talking about like stuff like domestic violence and stuff like that, I see a lot of times in our communities, we see that there's a lot of alcohol usage. There's a lot of that going on. I know people who dealt with that kind of stuff growing up. And the other thing I kind of want to talk to you about too is having a two-parent home. Does the alcohol, in your experience, even with the veterans, because I'm sure that we use that as a recreational default, where we say, I don't want to deal with this pain, so I want to distance myself from it as much as I can with this substance. It's the most accessible, and I can walk right out the door with it and just do what I got to do with it. You know what I'm saying? But then we found, even statistically proven, that it leads to a lot of other bad things. I mean, it's temporary for the moment, but you go right back down to that same situation you were dealing with. So do you find that that alcohol kind of like plays a factor in a lot of that stuff too, through your experience, and also in particular to the kids as well? Is it better to say that we have like a two-parent household, or does that really kind of like doesn't really make too much of a difference?
Okay, so let me tackle that first with the two-parent household. So I think overall research shows that when children have just like a loving, and we use the term like caregiver, understanding that always, particularly in our communities, the primary person caring for you might be your grandma, it might be your auntie, and so I think more than anything, it's that you have a consistent caregiver, not even a perfect caregiver. There's this concept in psychology, a theory called the good enough mother. It's kind of old school. So it says mother specifically. Even then it says, you don't have to be a perfect mother or a perfect caregiver. We just really need consistent, really like stable presence in a person who's responding to our needs in a childhood kind of stage as far as development goes. So, I think maybe a social discussion we can have about, the nature of the Black family and parent homes from that kind of perspective. From a logical developmental perspective, it's just important that we have a caregiver who is consistent and really is good enough. They don't have to be perfect, in order to have a child develop in a healthy, emotionally healthy way. We see so many things about alcohol. I think because it's like quote unquote legal, in our country, we feel like in general, just socially, the way we're socialized in America, we're socialized in a really kind of unhealthy way around alcohol. There's other cultures, Italy, and children even start drinking earlier, but they have a different kind of understanding and relationship with it. So we definitely have like a binge drinking kind of culture here. The more you can drink, the better. And I just recognize that's kind of like an American thing, culturally. But definitely alcohol can be disruptive to just so many things. I definitely see self-medication with alcohol when it comes to depression, when it comes to anxiety, when it comes to grief. People who have PTSD. I mean, there's so many ways that when the person first comes, it seems like there's an alcohol problem. And then you get to kind of do the evaluation and you realize, okay, the alcohol is really being used to manage these other symptoms. A lot of times people feel alcohol is safer. They're like, well, I'd rather drink, 2 or 3 bottles of wine than take medication. I feel like it's going to be better for me. That's the things that people tell me. And I'll say, okay, well, let's talk about the reality of what it means to, be consuming that much alcohol, particularly in the patient population I see, which is somewhat kind of mirrors Black and brown communities where we have lots of hypertension and diabetes, and alcohol can, because it's so many carbs, it can worsen diabetes and it can also contribute to hypertension. So on the medical side, there's just so many things that alcohol is disruptive to. On the psychological side, there's the self-medication piece. And honestly, I'm not sure if you've heard of a concept of harm reduction or if you're familiar with harm reduction principles, but kind of my orientation as it relates to substance abuse. So basically means you meet people where they are. Back in the day, they would come to the alcohol or any other drugs that weren't helping people, basically. Their use wasn't helping them. The goal was abstinence. You have to stop this totally, and again, sometimes it's just always not realistic to go to somebody who's having an alcohol problem, particularly if they're medicating mental health problems. Because if I say stop drinking, then what they're going to do with the anger, the rage, the anxiety, what they're going to do with it, So I can't sell that. People tell me straight up, if I don't drink, I can't sleep, I can't deal with people. So, they're going to have to, like you said, build that trust for me to say, hey, you can learn how to manage your emotions like psychotherapy. We can do anger management. We can do cognitive behavioral therapy, and we can treat your depression with medication to start, depending on how severe it is, we can treat that, So for me to say, trust me that we can treat it and you don't have to use alcohol to treat it. Otherwise, people just don't. And one thing, I'm real honest with my patients, and usually they're pretty honest with me, that I'm still drinking. They'll tell me. And then I'll talk to them. Oh, let's talk about like I said, natural consequences of drinking on this medication. How is it going to be if you keep drinking with your diabetes? But it's a non-judgmental, right? It's me saying, hey, it's your body and it's your choice. If you want to self-medicate with alcohol or if you want to drink this much, what is the natural consequences of that? And if there's barriers to quitting, what are those barriers? How can I help you get over that barrier, to quit? So I just try to take in general, a non-judgmental stance when it comes to whether it's cocaine, whether it's alcohol. I try to be non-judgmental and meet people where they are and say, okay, if we're using $100 of crack this week, can we go down to 75 straight up? That's conversations I have every day, and people, and then the thing is people say, okay, she's listening to me. She understands that cocaine serves a purpose for me. No matter what drugs people are doing, it's serving a purpose, so okay, she recognizes it. Okay. And as we continue to work together and build trust, then we can get to a point where we say, hey, you're down to $25 a week. What do you think about stopping? What would that look like? Could we get rid of the cocaine, what it's doing for you, and replace it with something else positive? Can we learn some other skills positive? Whether it's cocaine, marijuana, those are straight up real conversations that I have. But all providers do not have that harm reduction, that orientation. So they really are just people have to stop and quit. I just don't find that to be real for a lot of times. People just aren't going to go from 100 to 0.
Yeah, I agree with that. That's so awesome that you're so aware of that stuff, and it makes it easier for people just to say, hey, listen, I'm having this issue. And I think that's another thing, because even in a lot of homes, you don't feel comfortable going to, that parent, because you'll feel judged of some sort. Mm-hmm. And a lot of times it was a thing where you can't let somebody know that you're doing that. You can't talk to somebody about that. And to your point, it is very unrealistic to expect kind of someone to just say, you know what, I'm not doing this anymore, because it's just going to be withdrawal. You're going to end up having some violent stuff going on for what you want, or you're going to find a negative outlet because you're going to need it so fast. And it just doesn't really work out that well. I've noticed that, and in my experience and with my friends, when, some of my friends may have really good habits, some of them may have not so good habits. And I may say, someone may say, hey, listen, you want to stop that. And it's I'm not stopping it. Who are you to tell me that?
Right. Right. So it's people get defensive. So instead of being directive, you need to do, I get curious. Oh, what purpose is cocaine serving for you? You're not doing it unless it's serving some purpose for you. What is it doing? Oh, man, I'm so depressed. I feel good. I don't have to think about my problems, just whatever. Or, sometimes straight up, I have a lot of truckers, they're using to stay awake. They're trying to stay awake over the road, and it's, again, for me, I'm like, okay, how am I going to convince a person who needs that job? That's their livelihood. And they know it helps them, oh, I just do a little bit, hoppers, whatever I get. I mean, that's just the reality. To me, I like living reality about people's real experiences. And if I say, okay, you just need to stop that. And you're like, okay, but how am I going to make my money, doc? You ain't paying my bills, So we got to come to some agreement, Again, sometimes it's simple. Sometimes in that trucker situation, maybe they have a condition like sleep apnea. Maybe that's why they're having so much trouble staying awake. And they actually need a sleep study and they need treatment for that. Sometimes it could be that simple and somebody's doing cocaine over it. That's a real situation, I'm telling you. They have a sleep disorder. So things like that are just kind of my day to day. And I think as far as the comfort with talking, sometimes in mental health, and I mainly mention anxiety and depression, but sometimes people have other conditions like obsessive compulsive disorder, OCD, or schizophrenia. And in those conditions, people do have a lot of weird, bizarre, odd thoughts. If you're sitting in your room and you start hearing voices, or, you start seeing things, or, get paranoid, you might really be worried, man. This, especially at the beginning, some people are like, this sounds crazy, but it's real to me. They're scared to say something because they know it's not, that it seems off, and it can be scary, and so I think sometimes that's what drives people's worry about saying something, because in the case of those conditions, what they're saying or thinking really might be, they know people are going to think they're crazy if they tell somebody. If you think the government's controlling your thoughts, you're going to be scared to tell somebody, what they're going to think about you. And so that's where I think having that willingness to engage with the mental health system, because if you tell me that, I'll be again, I get curious about what's happening and do evaluation. And I don't say you're crazy. I say, oh, it sounds like you actually have this. This is this treatable condition, but if you tell people who don't know, some people get scared. You mentioned earlier about growing up in church. I definitely grew up in Southern Baptist tradition. And I'm honest, if you come to somebody in my church and say you hear voices or something like that, people would have probably thought you were demon possessed. That would be a common thing they would say. And they would tell you that you need some kind of religious, intervention to manage that. And so there's stigma, kind of coming from that area too, or just lack of understanding of some of these symptoms. So I don't want to get called demon possessed by the church or, put out of the church. I mean, that's real. People are dealing with that. So there's a lot of factors that go on to make people not want to come forward with their symptoms. Okay.
So you said some really cool stuff. So, yeah, when you do go to church too, there's always that mentality where it's you don't want to get shunned. You don't want people to look at you kind of weird. And that's your community. That's your group of people. You don't want to miss out on that. So a lot of times you tend to kind of not say anything. And then if you're a kid, you don't want to say something to the wrong person and they start looking at your parents different. And then your parents end up bringing it back onto you, because as Black and brown people, we get it enough from people outside, let alone we get it enough from each other. So in order to kind of mitigate some of those issues, we kind of say, you know what, don't say too much about this, be quiet about that. But retaining all that and not having a safe and comfortable environment to talk about that stuff, it really does more damage than it does good.
Exactly. And we mentioned earlier kind of about the more male, I feel kind of stereotypes, issues that they have growing up. And I think kind of on the other end, particularly as a Black woman, a lot of the messages I got, particularly from church, is that, don't let your heart be troubled. You kind of need to be long suffering. These people in the Bible suffered. And so I really got a strong message that, okay, life is like suffering, and so I should just expect that I'm going to have these issues. And then as a woman, right, we're carrying children and we're carrying the burdens of the world. And so I really got the sense I need to just be Superwoman all the time. And I need to just be protecting my family, the kids, my husband, just everyone. And that's also very unhealthy. So just the way the men are socialized to not have feelings and do all this, women are basically socialized to put on the armor of the Lord and just go out there. But guess what? we're people, we're not superwoman, and I find a lot, particularly with professional Black women who I see, they're burned out, they're tired, they're like so weary because they feel like they have to carry the weight of everything on themselves, so I definitely feel that having healthy spirituality in whatever form it comes in, if it's organized religion, if it's some other path, I think for, most people, that's a positive outlet, but we do have to be mindful of those negative messages we might be getting as it relates to mental health, because I can't tell you how many people who clearly have an anxiety disorder, up at night, mind racing, palpitations, panic symptoms. They're like, well, I can't let my heart be troubled. I know I'm going to pray God's going to take care of me. I'm like, okay, well, let's talk about that. Again, I'm curious. What does that mean to you to say God's going to take care of you? Does that mean that he sent you people into your life to help you? Could a therapist be part of God's plan for you? Could medication be a part of God's plan for you? Like, what does that mean? It doesn't have to mean I have to do it all by myself, because that's how it gets interpreted a lot. And that's, to me, very, it's unhealthy. It's people are just emotionally overwhelmed, and we see it just like every day. People are so tired.
How does that affect the child as well? Because now if the mother's dealing with that stuff, and then she kind of, where she ends up directing some of that stuff, how does that affect the relationship between, have you had situations like that where you see that the relationship between the parent and the child is affected in the overall, and then the child actually just has problems growing up, through the rest of his life with that kind of stuff?
I do. I think more than, because how I mentioned earlier, as far as it comes to like parenting and your caregiver, you just really need to be good enough. You don't have to be perfect. Nobody has that expectation. And actually, all this psychological research shows you don't have to be perfect. Like, you can just be all right, really, and your kids will be okay. You just gotta be all right. But when I'm approached with that, whether it's, even if it's a man, because sometimes men are like, I'm on my hustle, I'm on my grind, and they really are kind of focused on like the provider part of their role, often. And so they're like, I gotta, my family, and I want to have these like physical things. And so no matter who I'm talking to, how I pose it, again, non-judgmental, is to say, as a mother and dad or whatever caregiver you are the first teacher. And we know the main way that children learn is by what they see. So when you're overly scheduled, overly exhausted, maybe even having like physical conditions, because you're not sleeping, you're not eating well, you have all that's a lesson. You're teaching a lesson. And so I think that to me is the biggest thing. Even if you're doing okay, you're not a bad parent per se, but you are teaching lessons when you are not taking care of yourself or when you don't have the emotional health. And so I'll just always ask parents, what lesson do you think you're teaching your child by, working 16-hour shifts a day? They kind of come home to an empty house, or the grandma. And again, don't get me wrong, I grew up in a situation where mom was a single parent of 4 kids. She had to do what she had to do. I totally get that. But when we're overly, and we're just doing the most, I say, what are we teaching? That's a lesson, that you're teaching. And again, when I approach it that way, people don't perceive it as being judgmental. They might say, oh, I'm teaching that, having, this career is more important than this other thing. And that's okay to just acknowledge you're teaching a lesson. Is that the lesson you're trying to give to your children? That, being the man and being a provider means I'm never in the house. That's a lesson. Even if you want to, hey, but it's for college, it's for whatever, it's still a lesson that you're teaching. And so I think just to be very mindful for, people who are raising children, if you're a caregiver of any type, that you are teaching lessons with whatever you're doing. If you're not managing your diabetes and you're just eating whatever, you're teaching a lesson. The lesson is, I have diabetes. I do my own thing. I don't follow the doctor's instructions, and then if there's complications, a lot of children are like, oh, that means if I get diabetes, I might get an amputation. Well, most people with diabetes, there's a lot of people that don't get amputations, right? And even, don't get me wrong, I know sometimes people just have a really hard condition to manage, but I'm just saying as an example, if you're not managing it, then you are teaching a lesson about what it means to live with diabetes.
The difference between depression and anxiety.
Okay. So we have a definition of depression and anxiety. So I'm going to start with anxiety, because I have a way that I kind of, when I talk to people about it, because we would say like, we have nerves. You're a nervous person. I don't know if you say it that way, but that's what we would call it. So what I always ask people is, what does your brain do? If you feel nervous, and if they say, oh, my brain is very busy, or I'm preoccupied with a lot of thoughts, or I'm chronically worried. I say, okay, well, anxiety can be that. It can be mainly up here in your mind. And then I'll say, if you get nervous, does your body do anything? Oh yeah, I have sudden onset of shortness of breath, and I have palpitations, and I get sweaty, and I get dizzy. I feel like I'm gonna faint, and I just have to get out of there. Okay, that sounds like what a panic attack might be. So when I think about anxiety in general, it can be characterized either by symptoms that are mainly up here in your brain, busy mind, worried thoughts, a lot of negative thinking, always thinking about the worst case scenario. So that would be more what we would call like generalized anxiety disorder, chronic excessive daily worry. And then there's anxiety that can be in your body. And that would be more like panic symptoms. We have an anxiety attack, but panic attack is actually the book definition. And so what is helpful to me is when people have a condition, I just ask them what their symptoms are. Oh, doc, I lay down at night and I can't sleep. Okay, what prevents you from sleeping? Racing thoughts. Okay, so that kind of lets me know where to go with that. So that's how anxiety can be up here, it can be in the body, it can be a combination of those things. Whereas depression is kind of in a different category. So depression is considered a mood disorder. And in mood disorders, there's really, if we think about a spectrum, and over here we have what we call unipolar depression, just depression by itself. And then over here will be bipolar disorder. So there's kind of a spectrum along the way as far as symptoms go. But when we're talking about depression just by itself, we're talking about a condition where people have a mood that is a noticeable change from their baseline. And with depression, the mood can be, like, what we think of as like sadness, being tearful and sad. But one thing, especially in my guys, how they present often is with anhedonia. And anhedonia is basically a decreased interest or like things that you used to do, you can't enjoy them anymore. And so a lot of times if I just ask someone, are you depressed? They're like, I'm depressed, I ain't sad. I'm all right. But then I say, okay, but are you doing the things you used to enjoy? You know what? I used to play ball. I just can't get up enough motivation. I used to enjoy being with my kids, and now I'm with them and I don't feel anything. So depression, by the book definition, can be the sadness that we usually think about, or it can be anhedonia. So that's really important to know. And then other symptoms of depression can be trouble with sleep, and it can be either one, not sleeping enough or too much. The same with appetite, not eating enough or eating too much. And then problems with concentration, energy levels. Sometimes people can feel excessively guilty for like no reason at all. Something happened 10 years ago. Now all of a sudden they're like feeling shame and get overwhelmed with guilt. People can feel hopeless. And then when depression is severe, people can have suicidal thoughts, thoughts about ending their life. So for me, that's really even though anxiety and depression run together, depression is really a disturbance in your mood. People with anxiety may have an okay mood. They just have, the symptoms I described. Whereas depression is definitely going to be a change in, how you feel as far as your mood goes.
Now, that was very well put. Now, when you're dealing with things like depression, because I've had friends say that they think they have high anxiety, so they smoke, or they feel really depressed, so they'll drink to try to get away from it, and it says it makes them feel better because they're like happy. What are some ways that you could perhaps find ways to deal with stuff like depression or anxiety?
So definitely, I would say the number one thing I recommend is to actually, if people have access to it, is to have like a medical evaluation, because, and I think that's the part of being a physician and a psychiatrist. Sometimes I'll do the workup part if people don't have primary care, because there really are so many medical things that can kind of mimic a mental health condition. So the first thing I need to know is that you don't have any of those issues that is mimicking a mental health condition. For example, you don't have a thyroid problem, that you're not having blood sugar swings, that you don't have, any vitamin deficiencies that possibly could be contributing to the issues. And my fellas, again, I told you I work in a system with a lot of gentlemen. What's your testosterone like? Especially when I start to ask about the things they used to enjoy in this, they have a low libido and they have sexual dysfunction, okay, well, is that it, in the evaluation? So that's the number one. Let's be sure there's not a medical condition here that's causing anything like that seems mental health. And then the second thing my go-to is is psychotherapy. So I feel like, especially if it's your first time having these symptoms, if they're in what I would say like a moderate to severe range, meaning they're having some impact on your life, but you're still able to do your daily, you're still going to work, you're still, taking care of your family. To me, that would be kind of more in that moderate to severe kind of range. Psychotherapy. There's all kinds of psychotherapy. And I don't primarily do psychotherapy, but what I think is most important is you need to be seeing someone and getting a therapy that is for the problem that you have. So for example, if you have panic attacks and panic disorder, okay, well, that treatment might be different than if you have just depression, or depression is something else. So as the therapist, what are we doing? The therapist should be able to tell you what kind of therapy you're doing. We're doing insight-oriented psychotherapy. We're doing cognitive behavioral therapy for anxiety. They should have a name, or they should have an orientation for how they approach your case, your care. If the person can't really tell you that, like, what we're doing here, how many sessions? Is it 12 sessions? Is it, a year? What can I expect to be better? Those are questions you should be asking your therapist. For me, therapy is an intervention, just like medication, and getting the wrong therapy can be harmful to people, frankly. So that's second. So medical evaluation, go to psychotherapy. And then I would say if you've done those things and the symptoms are still severe, then, you would probably see a person like me, psychiatrist. If you're probably getting more into that moderate to severe range, that's usually when I would see a person. And then we will talk about, the risk and benefits of using medication to treat your condition. But that's generally how the flow to be, if we can. Sometimes we have to do medication and psychotherapy at the same time because symptoms have just progressed to that level. But I don't sleep on the fact there might be a medical thing going on with you.
All right. So the one other thing I have to ask, because can you do me a favor for the sake of the listeners? Can you tell them, because there's a negative connotation on psychotherapy. Can you please let them know the difference between psychotherapy and cognitive behavioral therapy?
Mm-hmm. And so I think, at least in my perspective, and you can tell me if this is kind of how you mean, I think when a lot of people think of psychotherapy, we think of, laying on a couch, the person's sitting behind you, because that's what we see on TV. And really what that is really a type of psychoanalytic therapy from Freud. A lot of us have heard of that name. He's kind of considered kind of the father of kind of modern psychiatry. And for the most part, you're not going to really find people doing psychoanalysis anymore. People do it. I find it most on West Coast and East Coast. You'll find more psychoanalysts are in big cities. But most people aren't doing that. So psychoanalysis would be that kind of therapy, but it's 4 to 5 days a week and for usually longer periods. So most people are not going to be doing that. Insurance, people who have it doesn't often cover that either. So that's not what you'll be doing. Cognitive behavioral therapy is probably one of the most popular treatments. It can be applied to a lot of different conditions. It really is on just, it says cognitions, your beliefs and thoughts and feelings about things, translating that into your behavior. How does it impact, and understanding how really your thoughts and perceptions really can drive your behavior and physical symptoms, and getting an understanding of that, particularly in the moment, learning how, if I have, let's say, particularly with anxiety and panic attacks, if you start to have physical symptoms of a panic attack and you think I'm dying, is that going to make your physical symptoms better or worse? Worse. The heart going to start, oh my God, maybe I'm having a heart attack and I need to go to the emergency room. And, and it can end up with people going to the emergency room. I had a person very recently who went about 20 days in 1 month every time they had the symptoms because their mind was telling them something bad's happening. And so CBT, cognitive behavioral therapy, can help the person learn how to control those thoughts and how that impacts their body's response to things, and the best way to describe CBT, and I kind of thought how thoughts can affect your behavior and your body, is I'll say that most of us, if we've given up to give a speech and we feel nervous or we feel butterflies in our stomach, we're like, okay, so they can kind of connect, oh, okay, so being nervous, being anxious, and it can affect me physically. The thoughts about being anxious, a lot of people have experienced that. So they're like, oh, okay. Because otherwise, if you try to say, hey, some of the thoughts you're having may affect your depression, they don't understand that. They're like, no, I'm just in this state. I'm like, no, some part of what's driving the depression is your thoughts and beliefs about what's happening with you, with whether it's triggered by a situation or whatever's happening. So So CBT, I mean, honestly, CBT is also popular. It is very effective, but it's also time limited most of the time. So insurance company loves to pay for, 12 1-hour sessions or whatever. So I think that's also kind of what drives its use. It's not always what's needed, but it's so helpful for so many things. But yeah, you're probably not going to be doing like psychoanalysis or like hypnosis. Again, when I watch a lot of movies, I see people like hypnotizing people. That, again, people are doing hypnosis, but not generally like, I would say like mental health professionals. Or if it is, it's a separate part of their practice. Like they may do hypnosis like smoking cessation or something, but they're not doing like hypnosis for depression. We have so many effective therapies that it wouldn't make sense to be doing things like that. So people don't have to worry that somebody's going to try to like hypnotize them or put thoughts in their mind or anything like that. That's not going to happen.
Do you find that that after someone sees a therapist that they that it was effective for them to see that therapist if they see the right one?
If they see the right one, so for me, that means someone you can connect with, someone you trust, and that that you have a goal. You should leave therapy. You should enter therapy with goals. And successful therapy should mean that, hopefully you've resolved some of them, maybe not all of them, or that you have some skills. So for example, when I ask people how has therapy helped them, what I'm looking for is like specific information. So, I have an anger management problem. I went to psychotherapy and I learned, these 5 ways that I can manage my anger in a healthy way, whether it's, walking away, counting the 10, using, grounding techniques or something like that. Like you should leave with more skills, or if it's interpersonal, if you're doing a longer term interpersonal therapy, you would hope that would play out, in your life. For example, some people like can't get along with people at work, they're always getting fired or quitting. And so, so if they go to therapy to kind of address their interpersonal issues, what I would hope to see is like they're stable in a job. Maybe their goal is to be stable in a job for 1 year. I'm going to not be fired or quit for this job for 1 year. I'm going to use my skills. So that's one takeaway I would say with therapy. Enter with a goal, and hopefully you have concrete ways that you're addressing it. Just like with medication. If I'm treating you with medication, when I see you for a visit, I'm going to ask you, how is your sleep? Like if I write medication for sleep, you were sleeping 5 hours, we should have a goal. Okay, the goal is, let's say 8 hours. And if we're not moving toward the goal, then we need to maybe make an adjustment. Therapy is the same way. A lot of times people feel like they just have to take the first person. And if they're not making progress, they feel like they can't leave. It's your time. It's your investment. Again, now if you just mad because the therapist like called you out on something, that's different. But if you're making progress, think about that, because that's the goal. The goal is to leave there with skills and progress toward your goal.
One other question I have for you was, how would someone with no insurance or not so much good insurance be able to see someone who can help them with their issues on a daily basis?
It's different in different states. So I looked up for New York. I'm just going to kind of compare that in Georgia, for example. In Georgia, our community mental health system is called community service boards. Whereas when I looked in New York, they call it mental health hygiene clinics. So they have different names in different states, but it's basically the same program. So every state, typically by county, they have to provide mental health services at low or no cost to people. Oftentimes what you'll see is it'll be based on a sliding scale. So if you do have some income, you may have to pay a very low fee for certain things, but community mental health centers are going to provide some type of psychotherapy service, some type of a medication management service, and then often substance abuse counseling. I will say, looking at New York's state system, it's a lot more that's offered there. So I think it's pretty progressive. So many different programs and things that are available. You do have to check by county. So after we're done, I'll send you the resource list and kind of how to navigate it, because I did have a little trouble actually kind of finding and getting to the place where I needed to go. So I'll send like the links that I went through to get to the area where the counties are. So if you have little or no income, then think about the community mental health system in the county where you live. In the city of New York City is organized a little differently based on the website that way. The other thing you can do is sometimes like universities, like medical schools and things like that, because they have trainees, particularly with psychotherapy, that can be a way to get either no cost or very discounted psychotherapy by seeing a trainee. So whether that's a psychology like student or psychiatry resident, psychologist who's in some postgraduate training, it can be a really good way to have that access to. And again, in Georgia here, Georgia State, for example, they have a psychology clinic and people can get low or no cost psychotherapy services. So, I mean, those are really the main two. If you have really bad insurance or if you don't have it, the community mental health system, or even looking at like universities, that's going to be the main two.
Do you find that if you have little to no insurance or bad insurance, do you find that the treatment is as good as it would have been if you had good insurance, or is it subpar in comparison to?
What I think is that depending on the insurance plan, and so I'm going to speak from an experience, like people who get insurance on the exchange. And again, that really varies from state to state, because some states, took money for ACA and some didn't. So like Georgia is an example of a state that didn't take it. And so most of the plans that are on the exchange, they do not have very good mental health coverage at all. Most providers do not take it. So even if you have like fairly good insurance through the exchange, the mental health coverage is not going to be good. And even though we have a mental health parity law that says in that whole country that says mental health services have to be offered on the same par with medical, in real life, it just doesn't often translate that way, unfortunately. So I think that if you can find providers who take it, I think the care in general is going to be fine. Most people who are paneled with an insurance company show their certifications and all that kind of stuff. So I feel like care you get, it doesn't mean it'll be substandard, just the access. It's going to be hard. Even having insurance, a lot of people in mental health, therapists and psychiatrists do not take insurance. I'm not sure if you found that in your you kind of nod there. So they do not take insurance. So we're already going to have an access problem. And the reasons for that is like a whole nother podcast, but they don't take insurance. And so already you have people who don't take insurance, and you kind of nodded your head. So, as psychiatrists, I can't even imagine in New York how much it would be, but a 1 hour eval in, I would say Atlanta would easily be between $350 and $400 for that first hour for us to see the psychiatrist. So that's not accessible to most people, and so there's already the people who don't take insurance, and then finding the people who do take it, it's a really challenging situation when it comes to mental health out there.
I do know some therapists that do take insurance, but a lot of times it's, the insurance will only pay up to this much and you're going to have to pay this. And you look at it and you get kind of like discouraged, like, do I have to? Or, it's rough. But I remember when I was in college, when I was taking psychology, my professor said, you have to weigh the cost out. Is it worth you kind of living your life with this? Or is it worth you kind of like doing what you can to take care of yourself and get through those issues? So, it's a balance between the two, but obviously you have to use discretion in those kind of situations.
I think my general orientation is I feel like at a basic level, and again, this is just probably a little political, but I think that we should just have universal insurance. And I do think some basic things like basic mental health care, psychotherapy, I think should be one of those things that's universal for people. I know that's at this point, it's probably living a pipe dream, but I think that's something, I don't think we should have to be weighing, can I eat out with friends, right? Because we know socializing, the pandemic has taught us that having social interactions is positive and being able to be with our friends and kind of engage, that's helpful too. I don't think we should have to be saying, can I eat out lunch or see my therapist? But I know that's how it is. But I don't think it should be that way.
You should have, you should be able to have, because it's essential. Your brain is everything that you use.
Part of your body.
Yes, you need that in order to function in this day and time, and anything that you do. So I totally agree with that. I feel like that should be very much more accessible, because at the end of the day, when you really look at the statistics, you see the numbers, Black and brown communities are the most affected by that kind of stuff. And I think that's a necessity. That's a part of something that we need in those kind of communities. It's definitely something that we definitely need in those communities. And we definitely need to take the stigma off our therapists and kind of understand that there are people like yourselves. And again, to evaluate and do the research for ourselves to understand that there are opportunities and people who are willing to help us that are not out there to kind of just make a dollar off us. Because a lot of times when we go to the doctor too, we kind of feel like, well, they're just going to prescribe me this or do this just to make more money and then have me follow up with them.
Right. I get that a lot. And a lot of times when I prescribe medication, particularly if people are new to it, I'll give them like a little mini like biology lesson about how the medications work, because what I do find, and I think this is like probably the fault of the medical system and how we're trained here in a Western system. But really, I tell the patient that we are partners. We're partners in your treatment because it's your body. If I'm giving you something you put in your body, we know there's risk and benefits to everything we do. And I want them to have an understanding of why I'm giving it to them. And I do know I have privilege in being a psychiatrist, that I do have an hour. When I see patients the first time, I have 30 minutes when I see them for follow-up. So I have a lot of time to talk to them and get more information. I know primary care doesn't, they're doing 10 and 15-minute appointments. They're seeing a lot more patients than I am. So I do have that privilege to be able to have those discussions and like give that education, a little bit easier than some other providers. But if a person, to me, it's always a red flag if they're just like, oh, I'll just take whatever you give me. We ain't doing that, because I don't want you ever to do that. Not just with me. Don't ever just take what people give you and not ask one question. No, I do not let them do that. I'm like, what are your questions for me? We need to be taught. We need to be partners. It's not just me giving you something, you just take it.
Hey, Doc, let me ask you a question. So if you're taking, so say for instance, you end up taking a medication for depression. At some point, is there possible, unless it's like chronic or unless it's, it's something that's a condition, it's a biological condition. Is there at some point where you could actually ease off the medication? Because a lot of times I find that we kind of think that once we take it for the rest of our lives. Is there some sort of, at some point, it's like some leeway to say, okay, I feel a lot better about myself. I've been seeing a therapist. I can kind of either lower the dosage or completely wean off the medication.
Yeah, I do that. Again, my population is probably a little bit skewed toward the more severe side. So people who have probably more that mild to moderate depression, a lot of times might be treated by their primary care provider. So people I'm seeing typically have more severe conditions and symptoms. But even that, I wean off medications for different things all the time. Sometimes we've met a goal. And so what I'll say is, let's have this plan of transition. And even after I take someone off of medication, let's say for depression, I'll usually see them about another 3 to 6 months, just to be for sure. Are we still able to, use our skills? Are we still maintaining our mood? Have we not had any new social stress that may have triggered anything? But, okay, we're good. And then they know that they can always, come back in the future if we need to restart it. But like I said, when you start a medication, you should have a goal. Okay, I'm trying to treat these symptoms. You should know what it is. And once you've done that, you should really have a conversation. What would it look like to stop? For me, typically a course of treatment is going to be 9 to 12 months. Again, I'm seeing people who are on a more severe level typically, who maybe have had suicidal thoughts or attempts or even psychotic symptoms with depression. People can have that. So in those cases, it's a little more complicated. And a typical course for me is about 9 to 12 months. And then if they're doing well, if they want to, I start having that conversation with them. I don't push people. So if people feel, no, I still need it for now, I don't necessarily push them off, but I do start to have the conversation with them.
Right. Now, that's really good that you said that. I also find that people also default to the idea that, and again, we were saying it can get expensive, but a lot of people also say that I can just see a friend or I can speak to a friend. But we had spoken about this off air where we were talking about your friend is not an expert in behavioral or cognitive therapy. So for them to sit there and talk to you, it's not really going to change the way you think or believe certain things. And it doesn't really, it may help you to get it out for the time being. It's kind of like, almost like you're smoking that cigarette or you're doing that, drinking. It's like, it's temporary. And sometimes it does help, but again, it's always best to kind of see a professional, because in those kind of situations, you're messing with people's lives.
Right. And I always have this joke. I always say, the Black women I know, they all think they got a master's degree in counseling. I don't care what they do. They got a master's degree in counseling. I call it sister girl counseling, and it's nothing wrong with using our lived experiences to help each other and to support each other. I think one of the points I made to you was that a lot of times the people we go to in our lives to talk to have other people going to them to talk to. And really, they can be overwhelmed and I think just to be mindful about that, what I call is like, what is their emotional capacity? Sometimes my emotional gas tank is not on F. It doesn't start full. I might be starting at a half a tank. And if I'm having to process a lot with people, even if I want to do it to be a good friend, it can be overwhelming. I think the other thing that's important to know for professionals is they have different boundaries. In my life, I'm not a psychiatrist to the people I know. I'm a friend or a sister or whatever. I'm not their doctor because I'm not impartial. I know you. I have some feelings about you before we started. Whereas when you're seeing a professional, they have different boundaries with you. And so that means they're going to be able to address things with you in a different way. So I think that's one of the ways that is different from just talking to a friend. And then I think they understand they have specialized training to help you. So particularly as it relates to trauma, they have learned how to help a person process through a trauma. The processing through trauma is different from just talking about it. Just talking about it with someone is just that. Processing and coming to a different part, understanding of the trauma and how it impacts my life and all that is different. And people have been trained to help you with that. Same with depression, trained to help you process that, trained to help you with anxiety. So it's different. The boundaries are different. The skill set is different than when you're just talking to a friend or a family member. Those are good things, but seeing a therapist is different.
Actually about to ask you about that. If people when you being who you are, do your friends also try to have sessions with you and like try to like use you as like, hey, listen, can I talk to you about this? And can you give me like an idea of, what I can do and stuff like that?
I think I have some friends I have like different friend groups, some from like college, some from high school, some from, my professional life. And one thing I really respect about my friends is that they really do see me as a person and they know that you do that for a living. You're hearing all kind of things all day. And so I think they kind of keep that in mind. They may even ask me, where are you at? Like, I got this, I want to vent about, where you at? And I'm honest with them. Some days I don't have it. I don't have the capacity to come home and now process, the marital issue or whatever it is. And it's okay. We might talk about it tomorrow. But to me, that shows like the respect and just the understanding, that friends can have with each other, to be honest, without people's feelings being hurt. And I do the same. When I want to go to a friend and talk about something, I'll say, hey, where we at today? Do we have like 30 minutes for me to kind of, go off about this one thing? Okay, good. Let's go off about it together, But if they don't have it, then that capacity, if their tank isn't full or where it needs to be, they have to go home and deal with their own kids and their own family and their own situation. That's perspective. Normalize asking people, can I vent to you before we do it?
Mm-hmm. Yeah. One other question I have for you was, what are some ways that perhaps we could probably, because I got to go based off what you said, because that was perfect how you were saying it before about being realistic about these situations and being in reality. What are some ways we can knock down some of these barriers where, we don't have access to some of these stuff in healthcare, where we can see a therapist with little to no insurance? What do you think would be some of the ways we can kind of knock some of those things down? Do you think that maybe, because I know they have school psychiatrists and stuff, but like, do you think that offering that as services in the community, or do you think that perhaps us kind of like speaking to each other, like saying, hey, listen, I know you don't have the money right now, but when you do get it, can you pay me for that? Do you think that's one way of kind of like doing that kind of stuff? Or
I'm a big proponent. I'm not sure if you've heard of the concept of mental health first aid. So how we have CPR, like, basic CPR, there's a class just like that called mental health first aid. So I think one thing we could do is kind of more broadly put that out there and like train people. We could even start with schools and mental health first aid. So what does it mean to be able to be a friend or a family member? Just like if I see someone fall down from a heart attack and I give CPR, I know I'm not a medical person, but I know I can follow these steps, right? It's pretty simple. I'm going to make 2 breaths and the same with mental health first aid. How can we recognize warning signs of a worsening mental illness? I feel like that is a way we can help each other, as opposed to, again, kind of just venting and processing with like people. That's okay. But I think like actually giving like a basic level of understanding of mental health and how do we recognize, if people start talking about giving away their belongings, and not want to be on earth anymore. That's, can I recognize that, and not just be like, this is plain, it's going to be all right. let me get a little curious. And once I think somebody might be in trouble, who do I go to? Letting students know that if they hear another student saying that, I can go to the teacher or to the school counselor. Letting students know when you hear something like that, that needs to go somewhere else, right? And even if your friend gets upset with you, whatever, if you're hearing that, you're being a friend by going to the right person, or even in your personal life, kind of identify if you hear that from let's say your mom, can the church mother or can the pastor be someone you go to? Is that a safe person, in your community? Because in the different communities is going to vary who's a safe person. It might be a mentor, it might be a coach, So I think that is, to me, the first thing. If we can more widely spread like just basic mental health first aid so people can know how to help each other in a healthy way. I'm not a super proponent of people getting things for free when it comes to treatment. And I'm going to tell you why. Because as it comes to mental health, I guess, because I feel like a lot of times when people don't feel like they're investing in it, they may not take it as seriously. So I would feel like if somebody paid me 50 cents, I want you to pay me something, because I want you to know that it's not just your time you're investing, that you're investing in yourself some kind of way. So I'm a proponent of, unless people really have no income and they really cannot contribute at all, then that's different. But if you have something, I feel like you should contribute something. But that's kind of my general philosophy. I think when people have some investment, they're more likely to do it. If I have a gym membership, I'm more likely to go because I'm paying money. It's coming out of my account every month. And if you give it to me free, I would like it, but it's probably not going to make me go anymore. I'll be like, oh, it's free. If I sleep in 5 days a week, I'm okay. I didn't really pay anything for it. So I think there's that concept there. Kind of as you say, if we don't pay now, pay later. I think let's just come up with the terms up front. Okay, and a lot of therapists actually do this. They'll say, hey, what can you pay? And even if the person says, I can pay $10 a week, that's what I have. Okay. So I think, the person like trusting you to let them know what you can contribute, and that's being okay, So maybe the other person is paying the therapist $250 an hour, but the therapist agrees to work with you. And some therapists really will have a certain percent of their caseload that they do that way, like what they call like a sliding scale, where they just let people pay according to what you're able to. So I think the model tends to work better, just psychologically. People feel like, okay, I'm contributing to what I'm doing here. I'm investing in what I'm doing here, but it's not breaking my bank.
Yeah, I had one that said she does 70 or 75 per session because the insurance wasn't going to cover it. And I was like, okay, that's not too bad. If you do it every 2 weeks, or, I get paid every 2 weeks, I'll do that every 2 weeks.
One cool thing I see some people on social media doing also is some therapists will ask for like donations, that maybe they have a separate part of their practice that has like a nonprofit status. So when people make donations, they take those donations and they use it for people to lower their price or to give it to people at a no cost. So I'm not sure if you've ever seen that, but some therapists will do that. They'll ask for donations and they use those donations to fund other people to be able to do therapy, which I think is really cool.
That's really cool. This other thing that I saw is that there's something going around now where you have phone sessions with the therapist.
Yes.
Now, I like that. I thought that's pretty, because some people don't have, a lot of people from where I'm from too, they don't always have cars. A lot of times they're taking the bus, they're taking public transportation, and sometimes we all know that could be unreliable depending on where you're at. So
definitely.
Yeah, so I think that's really cool. Do you know anything about that, or can you tell us a little bit about that? Oh yeah,
COVID has changed the ballgame when it comes to telehealth in every aspect of mental health, every aspect of non-psychiatric medicine. It has just flipped the script. So people have been doing that kind of treatment for a while, but before COVID, there was a lot of barriers to doing it. What for me it was like, what medications could I prescribe if the patient was in a different state versus if they were in the state where my license is. It was a lot of rules. And with COVID, they just boom. A lot of those rules, they just changed almost instantly. So I definitely think it improves access. I think a lot of the sessions seem to be a little bit more of a discounted rate. Some of the apps, it seems for some of those. So I think it definitely increases access. My actual job I have now is full-time virtual. So I see patients who are 2 hours away from where I live. So I'm definitely all for it.
That's awesome. Well, I have two more questions, but these will be the last ones. So my one is, where do you see the future of mental health going in general? I mean, outside of just our communities, and obviously, like we were saying, we need to have a huge focus on that. And this is why I felt like it was extremely important to have you on this platform to talk about this. But where do you see the future of this? Because I feel like from all the stuff that I'm reading, all the stuff that I'm seeing, there's more of a focus on like, hey, this is a serious matter.
I like to be positive. So I'm going to say, I definitely think the future of mental health is definitely like telemedicine and all kind of virtual interventions. I definitely see that. That's a wave that we're riding that's going to only continue to widen and increase access. It's hugely increased access in Georgia, where most of the psychiatrists live in Metro Atlanta or other metro cities like Savannah and those major areas. There's huge parts of the state that have no like psychiatrists at all for counties for hundreds of miles. So it's totally changed the game for us and down in Georgia. As far as it becoming more accepted, I hope so. I definitely see in like Gen Z and millennials and their generations, they're much more open to talk about their mental health, talk about seeing therapists, be very public about it. And for me, that is one way we fight shame and stigma is by not keeping secrets. Being secretive drives so much shame and so much guilt, and they really drive stigma. So that gives me hope for the future that these generations are more open about it and, not make as much of a big deal about it. That makes me hopeful for the future. But man, depending on where you live in this country, it can be pretty rough as far as mental health. Some places are very slow to change. That's like the most I can say. And I guess it's not unfortunate, but I do think that, religious backdrop, a conservative religious backdrop can kind of make the progress go a little bit slower in some cases. So, but I'm hopeful. I'm hopeful, and that kind of like to be on that end, just understanding the challenges that exist.
Discussions about what the culture is, but instead of how to fix what the culture is, where we were talking about earlier, the stigma of don't see a therapist, keep your mouth shut, don't say anything, and you just, you stay tough. Like what we were saying too about that effect on the kids with as an adult, you're always working with as a man or a woman. I mean, it definitely is something that needs to change. It's definitely something that we need to work on. And I'm happy that I was able to get you on here to talk about some of these things and break some, and hopefully clarify some things for some people who will be seeing this. By any chance, would you be able to give out your social media for people to find you?
Sure. I am primarily on Instagram. That's my main social media point. And I'm Real Deal Doc Dooley, and Doc is DOC, Dooley. I'm also I have a personal website, drleighanndooley.com. And I am on Facebook page at Leigh Ann Dooley MD, and on YouTube, Leigh Ann Dooley MD, the same there also. Awesome.
So I have to, again, appreciate everything that you've taken the time out and everything that you've taken the time out to do and your research. The other thing I want to say is, again, please, thank you so much. Congratulations for being the first female on this podcast. I'm so happy that I got you on here. Thank you again for your time and your professionalism.
Yeah, thank you. And I appreciate the opportunity. And thank you for everything you're doing to destigmatize mental health in our community.
It's a part of what as men we should be doing in our communities and what we need to be doing as our people, because the one part of it is it has to start somewhere. So this podcast is mostly built for economics and helping each other in general. So I can't thank you enough. Thank you so much for your time and everything that you've done. And
thank you again.
Also, thank you so much for serving our veterans of this country. And thank you so much for being a service to our community as well. I really appreciate you.
Thank you. Thank you again. Thank you for having me.
No problem. Thank you. Take care now, Doc.
Unactivated, I see this on both ways. Unity without accountability.